much for being patient with our technical difficulties. I am so excited for today's event. We will be featuring Dr. Nancy Klimas. Dr. Nancy Klimas, Chair of the Department of Clinical Immunology and Professor in the Dr. Kiran C. Patel College of Osteopathic Medicine, established the Institute for Neuro-Immune Medicine at Nova Southeastern University in 2012. In partnership with the Miami Veterans Administration Medical Center Gulf War Illness Program, the INIM is a multidisciplinary research and clinical institute that takes a systems biology approach to understanding complex medical illnesses, such as myalgic encephalomyelitis, chronic fatigue syndrome, and Gulf War illness. Dr. Klimas' research efforts have focused on understanding the pathogenesis and etiology of these complex immune conditions to better understand the underlying mechanisms of disease and to target treatments more effectively. Due to the complexity of understanding the underlying mechanisms of these illnesses, the INIM relies on a computational systems biology approach that can direct clinical laboratory research efforts to become more targeted and efficient. Her research efforts have been groundbreaking, and disease mechanisms identified with this approach are currently being targeted with FDA-approved pharmaceuticals and undergoing later-stage clinical trial investigation. Dr. Klimas is a diplomat of the American Board of Internal Medicine, a diplomat in diagnostic laboratory immunology, staff physician and director of clinical immunology research at the Miami VAMC. She has achieved national and international recognition for her research and clinical efforts in multi-symptom disorders, including ME/CFS and Gulf War illness. She is the past president of the International Association for CFS and Myalgic Encephalomyelitis, a professional organization of clinicians and investigators, and a past member of the Health and Human Services CFS Advisory Committee. Welcome, Dr. Klimas. We're so happy to have you here with us today.
Well, thank you. And let me get my picture to come up. Here we go. No, yay.
Yes.
Yay. We were having some technical difficulties earlier. This is great. Well, so thank you so much for having me. I'm so excited to talk with your group because you're just doing kick-ass good advocacy work, and I'm so impressed.
Thank you.
Pleasure that you invited me, and I'm really very happy to tell you a little bit about what I know and what I think applies to long COVID-related illnesses. Okay, and also to give my heartfelt gratitude to you for putting some money in a budget in a field that has had, been living on whispers and prayers and smoke and mirrors for 30 long years. And this year, for the first time, boy, have you gotten some attention. There were 200 plus applications to the recent ROA, 200.
Wow.
200 plus applications to that ROA that went out trying to develop the cohorts for the studies that will be going on. And if they didn't ever say, this Sutton's Law, why do you rob banks? That's where the money is. Well, why do you do research in a field? It should be from passion and curiosity, but it also takes money. And you guys just helped an awful lot to make Sutton's Law work for your own disease and diseases that are related. So thank you for all of that.
Mm-hmm. Well, I'm really looking forward to your presentation if you want to jump in that. And just for everyone watching, just so you know, we will have a Q&A session at the end of this event. Please try to keep questions relevant to the topic that Dr. Klimas is discussing. And just know that she cannot offer personal medical advice in our Q&A session. And with that, let's jump into the presentation.
So yes, like I said, thank you so much for having me. I'm going to frame this in the way that, of course, I would frame it because I'm an ME/CFS researcher for many, many years. I've been doing this since the mid 80s, believe it or not. I know I look much more youthful than that, but hey, I've been at this for a very long time. And actually my passion for this came from partly my feminism, because I was so angry at these women coming into my office that had been so patronized and dismissed by my colleagues. And frankly, that's still happening. So that's a little depressing, but it sort of energized me. And also I was in a unique position to jump in because not only am I a clinical immunologist, but I work with amazing people who do amazing laboratory science. And so I was able to really get into the weeds with these illnesses early on and start helping with the answers. So in a sense, I feel like I did all these years of work so that I would be in the right place, the right time for you, with the right team, with the right science. And we're very translational. We move bench work into clinical applications very rapidly. So I also like to hope, the word hope should be in my title, that I'm giving you hope because that's what we do. Well, let's see if I can make my slides advance. Why aren't they advancing? Ah, there we go. Okay, so this is the team that we assembled at Nova. This is like a very big team. If you didn't figure this out, we took a bunch of different people from other universities, wrote a really big grant for Gulf 4 illness, and we pulled our computational biology, as people that use like Watson kind of computers to try to answer big questions, into our bench scientists and our clinical scientists, and we created this amazing team with all of these amazing people. I think there's more than 60 of us now and 16 faculty members. It's a lot. And all we do is this kind of work. We're not distracted by any other illnesses. This is what we do. So, so we are excited to be in this field. The reason why I think that the work that we do in ME/CFS is so apropos to the post-COVID illness folks is, of course, that many of the people with ME/CFS, more than half, are triggered by a severe viral infection. And so if you go into the prospective studies, and there's only been a few in ME/CFS because we're a very poorly funded field, but prospective studies, you need to study a whole lot of people during an acute infection to find the very few that stay sick afterwards. And so that takes a lot of money. But there have been a couple of those studies, and basically they really taught us a lot about they were myth busters. They were actually mostly designed by psychiatrists, and they mostly thought they would discover that there was a psychosomatic or psychiatric or personality type that would be at risk for this illness. And in fact, there wasn't. The only thing that predicted who would stay sick after an acute viral infection was the severity of the initial infection and the immunologic response to that infection. And that predicted everything. And there were no psychiatric predictors whatsoever. And so back in the early fields of ME/CFS, the first 15 years, I would always be the only person who wasn't a psychiatrist on the expert panel. And now there's rarely a psychiatrist on the expert panel because while mood matters and chronic disease affects mood, it's not the driving force in this particular illness, ME/CFS. And I rather doubt it will have a whole hell of a lot to do with post-COVID sequela. Anyway, there's been a lot of case definition issues in ME/CFS. Researchers need to know about case definitions so that we study the same thing and we don't try to compare apples to oranges. So a lot of effort's been made in ME/CFS land to try to create a case definition. It's something long haulers don't have yet, and it is a problem. I just have experienced writing a great big grant, and we know that we don't have a case definition, and that we don't have the evidence to create a case definition. So one of the first goals in early part of the research is to know who we're studying and define the group. But this is what we did in ME/CFS. Since it was a fatigue predominant illness, fatigue was a requirement. Exercise relapse was a requirement because that really does happen in ME/CFS. Non-restorative sleep was a requirement. Waking up exhausted is part of the usual presentation. And then either cognitive impairment or orthostatic intolerance. That was evidence-based. So this was an Institute of Medicine panel that I sat on with a lot of other amazing people who were just, I'm amazing too, of course, but they were really amazing. But they reviewed every single paper in the field. And this is basically the clinical case definition we developed. And it's now the case definition we use. Now you can see there's a lot of overlap then with long COVID because severe fatigue, brain fog, cognitive dysfunction, and oh my God, autonomic dysfunction, such a predominant feature of long haulers that I think that these case definitions are going to end up overlapping greatly. And I would anticipate as an ME/CFS researcher that they're going to overlap. However, you got to do the science to figure that out. And we're actually doing that study right now. You would be familiar with a lot of the long hauler stuff. I'm sure you've heard other people talk, but you can see that there's a lot of people who remain ill after COVID. And not just the people that were in the hospital, but you'll see that a lot of the research is focused on the people who were in the hospital, that they were the people that got the follow-up. And of course, what happens to people who were hospitalized versus people who had a milder or moderate form of COVID and didn't require hospitalization could be quite different, because you would anticipate people who were in the hospital, particularly people who were ventilator supported or had a lot of lung or heart or brain things going on, might obviously have sequelae. And that might not be the same driving force that's behind long haulers, or whatever we're going to ultimately call this illness. So, but you see that most of the literature actually is post-hospitalization. Oops, come on, you can do it. So 3/4 of the people that are hospitalized had at least one symptom that was still persisting 6 months after the acute illness. So that's a fair amount. That's a pretty good sample. This is a Chinese sample of 1,700 people, and fatigue was the most predominant symptom. But the illness affects, acute COVID affects multiple organs. And so there's a lot of work that needs to be done to figure out in the acute setting, what would set you up for a chronic disease, but also in the chronic setting is something new emerging over time that's a sequela of this illness. And of course, something that's unique to SARS is this ACE2 receptor that this virus actually attaches to the vascular lining by way of something that's really important in autonomic function, the ACE2 receptor, which is in all kinds of tissues all over the place. But there's a tremendous dysautonomia in the long haulers, and this, whether or not COVID incited some sort of dysregulation of the way these receptors are going to be expressed, or an autoimmune response of some sort to these receptors, and so on. There are many questions that need to be answered. So again, this is more about the dominant organ systems, but brain, blood vessels, heart, lungs, gut, and so on. There's only been a small series of studies to know whether or not COVID actually infects the brain. Obviously, the brain's got a lot to do with how bad you long haulers feel right now. And so the question is, did COVID get into the brain to begin with and do something? And the only study that I'm seeing quoted right now is the one by Dr. Nath at the NIH. She did a whole series of acute COVID autopsies, and did not find virus in the brain. He did find a lot of endothelial problems, clotting, microvascular problems, tiny thromboses. And so he was postulating that perhaps some of the long hauler issues have to do with blood flow in the brain as it relates to that, or maybe some persistent inflammatory driven thrombosis, which is clotting. But we don't know that. It's just, hypothesis. But now we have this illness, the long-term sequela, where we're looking at these organ systems and thinking about it. But I'd ask you to reframe it a bit, because if you come back to ME/CFS and what we know about ME/CFS, it's a whole body illness. And if you get too focused too lens focused on an organ system, you might miss the big picture that really tells the real story. And so all of our work in ME/CFS and in Gulf War illness has to do with homeostasis and the balance, the hormone balance, the inflammatory balance, the immune, neuroendocrine, and all the various tissues balance. And I think that perhaps it's better to stand back and look at the big view and try to learn about the quilt, the whole image that emerges from the puzzle, than looking at the individual pieces too intensely. Not to say that we don't need to dig deep right into the cellular level, but rather always pull back then and say, what does that mean to the big picture in what's going on in these patients? And this was a study that was published right around January, I think, where 1 in 5 patients who had not been severely ill had a lung impact that had not gone diagnosed. And this is coming up very commonly in the post-COVID workup. When your doctors are seeing you, it's really important that they check out your lungs, really important they check out your heart. These are not things we normally do in ME/CFS patients, but you had a disease that infects the lung, infects the heart, and so on. And it's quite possible that you could be silently going along with only part of your lung function, or with a cardiomyopathy that's been undiagnosed. And so, with at least at the very bare minimum, what we're begging doctors to see post-COVID patients to do is take them very seriously and do the workup to make sure there's not been organ damage during COVID that had not gone diagnosed that needs to be treated. And so this is a study, and in fact, we're doing this 6-minute walk test in our research now to help us understand lung function before and after exercise during a simple 6-minute walk in clinic. It's a screening test. So when you're looking at long hauler's disease, because all those symptoms I just talked about, fatigue and autonomic and this and that, there's the whole laundry list of symptoms people are suffering from, could easily also come from organ-specific damage. It's terribly important to think about, particularly heart, lung, and brain. And if I were a long hauler, I'd be looking my doctor right in the eye and saying, I need at least a pulmonary function test, but perhaps I need a CAT scan, and oh, by the way, I need an echo. And oh, by the way, how do you know my brain was really not impacted by this? And perhaps even a CT or an MRI of the brain. So I actually do imaging in my patients to make sure that nothing was missed. That's a consequence of having acute COVID. That could be treated and help us better understand what's going on in the patient. So one by one, patients, every person being an individual, and you can't smear this whole group together and say everyone should be treated like, the same exact regimen. But at least diagnostically, we need to go through a serious set of diagnostics to make sure that people who are staying ill months after the acute infection have had their primary major organ systems checked out. Now, prolonged symptoms are common in even in people with mild COVID. And this is a French study that showed up to 54% of patients had persistent symptoms in 2 to 4 months. And 50 to 76% report new symptoms that weren't present. This is one of the questions that's in my question and answer thing. Why are you getting new symptoms after time that are appearing over time? And 9% of the people that presenting with the acute symptoms, or rather symptoms post-COVID, report them as severe. So you can see then that there's a lot of different types of symptoms. And I keep going back to my ME/CFS thing, but the fatigue and muscle weakness is so common in these post-viral illnesses that I think that we can understand them with some decent work. The sensory disturbances are interesting because they're sensory, meaning taste and smell. Well, that acute COVID, infected near the nerve endings for those things, and there was nerve damage and has to recover. And it does recover, but it takes a long time. But the sensory disturbances that are happening from peripheral neuropathy are different. And we're having to find out whether or not those are perfusion or if they're autoimmune, what's going on with there's neuropathic symptoms. And these other symptoms you see, a number of them are fairly autonomic. Headaches are very common. And of course, cognitive complaints. In my experience with ME/CFS, cognitive complaints are what make people stop working. They usually work through their fatigue, even though I don't know how, but they try. But when they start making mistakes at work because of cognition, that's usually what makes them stop. And so a number of people with post-COVID illness are also finding that they are not able to continue working because the cognitive dysfunction is severe enough to impact their ability to continue performing their jobs well. This is more of the same, but I use this to say that women are more likely to get this than men, which is always true in illnesses that are inflammatory. Women are more pro-inflammatory than men are. There's some endocrine reasons for that. Testosterone turns out to be a terrific anti-inflammatory. But But again, the other one I wanted to point out is that seniors. We hardly ever study seniors. They're almost always an exclusion in our study. We study people, whatever, 18 to 65 or 18 to 70. But the risk for post-COVID symptoms is 22% in this study compared to 10% of younger people if you're over 70. And so we really have an obligation to our seniors that are post-COVID that managed not to have severe enough COVID to, they thought they got through it. What a disaster to have gone through COVID, not happily gone to the hospital and been ventilated and all the things like some of our seniors had to experience, survive it, or you discover you have a chronic illness afterwards that you're having to cope with. So much, I think we have a real urgency there. And a real important thing when we're designing our studies to not leave our seniors out and in fact to double down there. So this is our study, and part of the reason why you invited us is we're happily one of the early people to get funded to study post-COVID or long haulers type illness. In this study, we actually are asking the question whether or not long haulers and ME/CFS overlap biologically as well as clinically. And so this is a sort of a combination study that has a longitudinal component, a 4-year study where we're following people for at least 3 years, using mainly surveys, self-report surveys, but pretty intensely deep looks using surveys at all the various symptoms, domains of illness, severity, and impact on function, and so on. This is a study, this longitudinal component of the study, we're actually going to a patient base of around 50,000 people to hope to recruit 2,000 people who have long-term sequelae, and then follow them longitudinally. From that, we're bringing in 200 people to do a phenotyping study, bring them into the clinic and really dig deep into the biology of the illness and do echoes and pulmonary function tests and so on, as well as looking biologically at what the laboratory-based mediators might be. So this is launching actually next Tuesday. Just took a long time to align this protocol. The CDC, when they fund something, it's not a grant, it's a contract. So they have a lot of hands-on with the study group to align it in the best possible way, which is fabulous. We've had the ability to work side by side with these amazing epidemiologists and study design people in CDC and tweak the study towards perfection. It's not perfect, but by God, we're launching on Tuesday. So we're real excited about that. We're finally off the ground with the study, and we hope to give you answers as quick as we possibly can. So as I described, we're looking at this large group of people, more than 2,000 longitudinally. It's the other exciting thing about the study, those of you that don't know South Florida, we're a demographically rich place. And so this study, which is based in Miami and Broward and Palm Beach, Miami's 80% Hispanic and African-American, mostly Hispanic. The demographics of Broward aren't 80%, but it's still very rich. And we're being able to base many of our recruitment sites in high-risk population areas like immigrant places that work with the farm workers and other people that have poor access to healthcare. So for me, I'm really excited. And ME/CFS, for years, the funding's been so poor, we've never been able to do a really good demographically perfect kind of study to look at whether or not in ME/CFS, people who if there's any ethnic variability or what socioeconomics due to presentation and so on. So in this, we're going to have this very rich demographic to work from. And I think that's actually perhaps the best part of the study. And I think it's a great study in every way. I'm so excited after all these years of doing ME/CFS work and feeling like I've been dealing mainly with a biased clinic-based population that I'm finally able to do this better design and really answer some really important questions that need to be answered. The other thing neat about this study is that we have two really big cohorts that are already studied with a very similar design that have ME/CFS that we'll be able to compare to. We just completed a study with the CDC in 2019 with a lot of other investigators where we studied 750 ME/CFS patients on site doing phenotyping. So we'll have that, plus all the work that our group has been doing for years in different studies that we have for comparator groups. So that's great. It's a good study. I'm excited about starting it. I just got off the phone with the study group and we're all very excited about getting this thing off the ground. So one of my points with this group is you're not starting from scratch here. I know it feels like you are, you just got sick, this is a brand new illness and so on and so forth, but actually ME/CFS has got 30 solid years of science being done, albeit poorly funded, but by God, we've been doing it anyway. And there's just a lot of work. And there's also a lot of clinical experience from really fabulous clinicians to help us better understand the illnesses. And since ME/CFS has the autonomic component, the blood pressure fluctuations and tachycardias and all that, the flushing, the GI irritable bowel and all those kinds of parts to it, in addition to the fatigue and so on, there's actually a group of very experienced people out there who are already have treatment guidelines up and published that can be downloaded and you can bring to your providers or direct them to the website and get some understanding on how to approach these complicated illnesses and what to do about specific components. I have that in a later slide. I'll be sharing it with you. Also from ME/CFS, we know, like I said, you can't look through one lens and expect to explain it. If I'm an immunologist, I spent years looking just through the immune lens and I found lots of answers there, but it didn't explain it. All right. It was enough to help people. And I was certainly helping people, but I wasn't helping people the way I am at this point when I work with these more integrative functional practitioners that look at whole body approaches. And I overlay our homeostasis concepts from our research into that space. And we get much better outcomes now in our clinical practice because we're learning from the science, but we're putting it into a treatment platform that doesn't ignore the interactions between all these systems and how important it is to understand all of that. So one of the key components of ME/CFS is inflammation. And as you can see already from the early long COVID work, one of the key components of long COVID is going to be inflammation. And systemic inflammation, but also brain inflammation. Neuroimaging studies in ME/CFS done just in 2014, which is only 6 years ago, using PET scan, really nailed this for us. You know, up to then it was kind of controversial. Was brain inflammation even a player? And now with this kind of imaging technology, imaging that if any of these studies get funded from the 200 plus studies that are currently under review, they're all proposing to look in these kinds of ways, I'm sure. But using PET scans, you can actually image the brain inflammation and you can see it. It's there. It's not questionable. These studies that were done in Japan have been since validated by multiple groups. Another player in the brain and in the body is oxidative stress. And I can't underscore enough how interactive those two things are in the brain. Oxidative stress drives inflammation, and inflammation and immune activation and all those cells that are charged up drive oxidative stress. So in any treatment approach, you have to take both on. You can't just think you're going to fix things by just hitting one button or another. And so again, I'll talk in a couple slides forward a little bit about how you go about doing that. But I want you to hear me say oxidative stress in your body matters. Oxidative stress in your brain matters, and it matters a whole lot more the older you are. If you're over 40, a healthy control already has oxidative stress in their body and in their brains. They've already got an imbalance of antioxidants in their system. But when you just went through a critical illness like this, a much younger person is going to have oxidative stress. And if they depleted their resources during the infection and didn't replete them, they still have oxidative stress. And you can treat that, you can fix that. Hormone regulation is a player in ME/CFS. I don't know yet in in long haulers. We're going to find out. In my clinical practice, so far, that's been true. I mean, but of course, that's my eyes and not researching eyes, but clinical eyes, seeing it. So far, my ME/CFS patients and my long haulers really look a lot the same. So, but the balance of hormones matters. One of the questions in the question answers is, why do I get sick during my menstrual cycle? And the answer is hormones really matter. And just, and that's very, very true, that in that most women that during their cycle will have flares in ME/CFS of ME/CFS-like symptoms that they can predict this cycle with their cycle. And in fact, one of the treatments in ME/CFS is to use the kind of birth control pills that limit the number of cycles you go through a year if you're not trying to get pregnant. And that actually really helps stabilize some of those cyclic relapses that are so predictable. But hormones matter in our modeling of treatment. In our group, I say we use these Watson kind of supercomputing strategies to do millions, and I'm not exaggerating, millions of clinical trials in silico, in the computers, almost randomly hitting every button in the body in various combinations, trying to see if we can reboot or reset the homeostatic networks back towards normal. And in all of our female models of this illness, we have to either time the intervention with a cycle, or we have to influence the cycle with hormones. So actually, there's a big gender difference in the kind of models we have for intervention. And in women, we have to take into account cycles, or if they're postmenopausal. In men, testosterone levels matter too, and they matter more when they get older. So putting it all together for us in our modeling effort is homeostasis. And in this, we have a moonshot vision. You know, everyone should have a moonshot. A moonshot for us is cure. And of course, in our ME/CFS populations, we have people who have sometimes been ill decades. So talking cure to them sounds crazy talk, but we're not thinking we're crazy talk. That in silico models and in our animal models of similar illnesses, and I will say there's no animal model for ME/CFS that's been established that everyone says is the best model. But at least in our Gulf War illness models, where there is an animal model, different kind of brain injury, but long-term sequela is the same. We can cure the mice. We know how to cure mice with our homeostatic reboot modeling of those illnesses. And we predict and hope that we're going to be able to reboot ME/CFS if we follow the same modeling strategies. And where we are in that work is very far, that we've been doing it for about 8 or 9, 10 years now. So for Gulf War illness, we've got the models established in men and women. We got the animal data to show that it works. We're in phase 1 trials in men. We've just asked for the phase 1 money to start in women. And we already have phase 2 funding if we're successful in our phase 1 trials. So that's very exciting. So that's taking a computational modeling strategy to a really complicated illness and putting it all the way through from bench to human trial. So we're excited about that. In chronic fatigue syndrome, where there's no animal model we can do it on, as long as we use with safe repurposed drugs, we thought we'd just leap into human. And so we have some private funding to do those studies. We had to put them on hold for the year of COVID hold, but we're just now back in front of the IRB getting the approvals to start up those studies. And we have, again, phase 1 funding, somewhat limited, but some phase 1 funding for men and women. And that we hope to then find funding mechanism to move it on to phase 2. So that's exciting. And we would propose in long haulers that we could rapidly come up with the same kind of modeling if we get funded to do it. And we are, of course, writing those grants. So going for the cure, it's really what we were talking about in this moonshot stuff. And we are actually rebalancing all these key systems in the brain as well as in the body. And in all of our models, just pushing one button is never enough. We can't just hit one system and make it all better because they're so interactive that we actually have to hit 2 or more systems. So here's the idea in our models. So I want to make sure I'm not running too much out of time here. But in our models, we say normally in health, let's see if I can make my arrow work. Normally in health, you sit in this space, you get the flu or COVID or something, and you fall back after you're ill back into normal. But when you're sick, you kind of climb up this mountain. But if you're really in trouble, you climbed up the mountain during acute COVID and you fell into this well. And now you're stuck in this post-COVID illness, and you can't get out of this well unless you climb the mountain and fall back in over here. So our modeling is actually stirring up enough mess in your systems to want you to change status into a new status, and then we direct you down the right mountain and to fall into the new homeostatic network. That's the idea behind the trials that we have envisioned. And like I say, they're supercomputers. In the Gulf 4 illness, we have to reduce inflammation in the brain for a period of time, and then we block the adrenal axis very briefly. Then we basically reboot the whole adrenal axis by blocking and then unblocking. And then everything sort of realigns back into the right alignment in silico and in the mouse. And now we're finding out if that's true in the human. But we did in our studies show very strong gender differences, and that 1-2 punch that we're doing in men won't work 1-2 in women. It needs a third punch, which is manipulating estrogen. So that's the trial that we just wrote and hope to get funded. So you can see what we do. This is my slide. The guys in the computational lab hate this slide, but I love it. We put everybody on the bike and figured out what was going on by drawing 9 bloods over 24 hours, actually 8 of them in the first 4 hours after an exercise challenge. Measured every gene that got turned on and off, every cytokine that's expressed, every hormone that's released, what the cells are doing, what their function is, what the receptors are doing. All that data goes back into the supercomputers to create, using chaos theory. That's the only slide I could figure for chaos theory. And create these models, and then these in silico trials. And then we test it in the mouse. And if it works, we go on to human. If not, we give that data back to the modelers and they give us better models. And then finally, ta-da, we hope for health. That's the idea. So our future directions in this work is in ME/CFS is to move on with these phase 1s and go forward to get through the phase 1s and move on to phase 2, to constantly improve the models with new ways of getting better and better data that inform these models in a way that they get tighter and tighter and give us better predictors. And then now move into post-COVID modeling. And that's absolutely where we want to be. And of course, you can be sure that we're writing those grants and hope that maybe some of that new funding you found for the field will fall into our laps so that we can do some of that work. So I'm going to move from that. That's what we're doing to what you might want to actually hear from me as a clinician. So I'm changing hats, okay? And I'm going to say this is a slide I stole from one of the post-COVID slides, because this was the World Health Organization slide that's up on their webpage to say, what do you do for people? And this is good advice. It doesn't take it far enough, but it's pretty good advice. It's saying, treat the whole body. Make sure you do a very good symptom evaluation, measure the systems and make sure the systems, pulmonary function tests, echoes, CAT scans, and so on, to make sure that there's not a damaged system that needs to be addressed directly. When you fail to find that, that doesn't mean they're not sick. It probably puts them into this more ME/CFS-like category, and they can be treated using those kinds of strategies. And then when you are taking care of patients with post-COVID, it's multidisciplinary. It's not single systems, like going to an immunologist and only taking care of your immune system wouldn't be good enough. But also that there's elements that you can help with yourself in terms of self-care. For me, self-care is really recognizing what your limits are and respecting them and not trying to push through the pain to the point where you're constantly relapsing. That's the worst thing all my patients always do. But then to use your primary care doc well and do your specialty teams if you need them well. Rehab is very carefully done, and you can really make yourself a lot sicker if you push too hard in the rehab space. So it needs to be done with respect to what your limits are and understanding that your aerobic capacity, your ability to do work could be extremely limited. You might look great and you might only have 3 minutes of effort in you, in which case you only get to do 3 minutes. And so that's very personalized. And maybe I have a slide on that, but I can take it in the questions if anyone wants to hear more about that. in addition to these kind of guidelines, you have to really stay tuned in because things are changing really, really fast. And one of my favorite things is the patient as scientists work that's going on, the patient-led research collaboratives. And you all have, many of you have been involved in this, filling out those surveys. They are tedious, they are a pain in the ass, but it's the way we learn. And if you're not willing to sit down, and if it's a 45-minute survey, go ahead and do it. I mean, this is how you share knowledge. There's a site called Patients Like Me that also has a really nice thing that really asks you questions about what's helped you, what's hurt you. Those are very quick turnaround spaces for people sharing data. And these patient-led research collaboratives are publishing their data. They're getting really good data out there. Many of you people who are ill with long haulers are actually really amazing scientists too, and have helped design these kind of instruments that are being used. Damn good science going on, and it's patient-led research. So very cool stuff. While you're waiting for answers, the first thing that you want to do is first, don't give up. It's so important for people to recognize how easy it is to lose your way when you feel this badly. And sometimes lose your perspective that things are getting better, that research is empowering new knowledge, that this is a remit and relapse illness. And when you are relapsing, it feels horrible, but there is the comeback that makes you feel better. And I think the hardest part of these illnesses is actually riding that roller coaster that you thought you were better and then you slid, and then you had to wait to get better again. And rather than get too sucked into, oh crap, here I go again, instead, try to look for the patterns, because often those slides follow too much effort. Going, trying to get back into the gym, a change in medications, a change in diet. Sometimes you can find the pattern to your relapse. And so, so be aware. Sorry, my grandbaby is crying in the background. There might be a little noise. So be, again, like the physician scientist, instead of getting drawn into your relapse and thinking and losing hope, instead, use that great mind of yours and look at your patterns and see if you can start to get your predictors and see if there's anything there that would help all of us know better how to manage this illness. Now, these are the websites, and I will share these slides so you guys can have these. So you just have the link, but this is the ME/CFS Clinician Coalition. So that's easy, ME/CFS-cliniciancoalition.org, all the guidelines. This is a group of, I think, 38 physicians. I'm a part of it. There's a whole lot of other amazing doctors who've done ME/CFS collectively. I think we did the math that we had something like 4,000 patient years worth, doctor years worth of experience in this room of people who were putting their heads together saying, how do we collectively want to do this? This website, Court Johnson's one of my personal heroes. He does healthrising.org. I don't know how he does it, but he puts really complicated things into English and really helps explain the state of the science, what's exciting, what's out there, and what's helping people. And he has a great blog that's going on there. And of course, this is our own website. And we do lots of conferencing. We put all our events up. Everything's on video there. You can see an awful lot of information if you play around on our website. We have Twitter and all that stuff too, but I didn't put it all up there. And our social media person's going to be upset with me for that. Sorry. How am I doing? I'm great. Okay, so this is just my call out to use the ME/CFS knowledge to help long haulers until we know otherwise, because we know a lot. This is a busy slide, but it's your biggest take-home slide. We treat a lot of elements of this illness, and we try to cross the blood-brain barrier when it's necessary. So inflammation, brain and body. What treatments cross the blood-brain barrier? We use low-dose naltrexone. You can read about that one. Google it with, say, fibromyalgia, and you'll find some cool studies. Nanoparticle things like nanocurcumin crosses the blood-brain barrier. Omega-3, if you use enough of it, you need to get about 4 grams, four capsules a day to get to the point where you're getting anti-inflammatory effects, but it's pretty effective. Bioenergetics. I said you can't treat oxidative stress in the brain and not treat inflammation and vice versa. So bioenergetics, this has got everything to do with mitochondria and all that. So again, crossing the blood-brain barrier. The best thing for crossing the blood-brain barrier is NAC, N-acetylcysteine. It says NAC on the label. You don't have to remember the big name. But there's a beautiful study going on by Dr. Shungu at Cornell that's using 900 milligrams twice a day. And he's getting, in chronic fatigue syndrome, getting normalization of antioxidant levels in the brain doing that. We also use compounded intranasal glutathione as another strategy. There's many things that affect oxidative stress in the brain, but COPA is something that affects oxidative stress in the brain. So a lot of different types of things that can be helpful. I'm giving a lecture right now, sorry. Poor antiviral function. So we don't know enough about this in post-COVID illness yet. In ME/CFS, the immune system's broken in a way that it can't prevent old viruses from reactivating as well. So the natural killer cell function and other cytotoxic functions are affected. So in my long haulers so far, everyone I've checked for NK cell function, it has been poor, but I haven't enough yet to publish that paper. So I'll find out in time if that stays. But I'm assuming that viral reactivation matters in long haulers. And we assess immune function in our clinic because, hey, we have an immunology lab, so we can do it. But this is somewhat trickier with Quest and LabCorp type labs because those kinds of assays are kind of tricky. But then the question is, what do you do? And there are some things, again, go to that website and you'll see what other doctors do and what we do as well to try to improve immune function and try to get viral reactivation under control. Mast cell activation. This may be the most important cell in long haulers. And certainly we don't know yet. We're going to do a lot of research around that. I know we're writing some grants with Dr. Ferrerides right now at Tufts, trying to get more at this. But there are mast cell stabilizers. There's a lot on that webpage that I just sent you on how to do mast cell stabilization. And it's really important and it can really help a lot. So underscore mast cell activation. Dysautonomia. That's the blood pressure control, posture orthostatic tachycardia. I don't know yet in long haulers if this is going to be true, but in ME/CFS, there's also at the same time low blood volume, and correcting blood volume helps. So that's simple. That's electrolyte solutions. You got to kind of worry about all the dyes and things in Gatorade and things like that. But if you can find sort of the more organic or natural forms of electrolyte solutions, and there are many choices there, and actually drink 16 ounces or even 32 ounces a day of electrolyte solutions, you might see your blood volume normalize and the autonomic dysfunction improve just from something that simple. But again, your doctors are also consider prescribing beta blockers or alpha-1 agonist midodrine, which can be very helpful. The endocrine thing actually needs a workup, needs the labs to be done. Just look at your thyroid and your estrogen and testosterone if you're a guy, and cortisol levels to see how that's going. And that's important. And then finally, I'm going to underscore the importance of sleep and that there's also a very frequent upper airway resistance thing. It's just like the fatigue in your body, the muscles in the back of your throat sort of relax while you're sleeping and actually allow the obstruction of your airway. So very thin people who don't meet their normal criteria for sleep apnea actually have sleep apnea. And a sleep study is very helpful. If you wake up exhausted and non-restorative, that's an indication for a sleep study. And there are some things that can also help the quality of your sleep, which I listed here. So that's it. I got to that. This is in the background, you heard this one, the little one screaming. And the bigger one hasn't come snapping into my lap yet, but normally it's about the time she hits me. So if anyone has questions, I can try to answer them.
Thank you so much for that, Dr. Klimas. That presentation was really excellent. We have quite a few questions. Do you have a few minutes to extend past the
I
hour?
do. If you guys do, I should say before I say that, let me double check my thing, but I don't think I scheduled anything after this. So yeah, protected time. Hey, you're good. Yay.
Excellent.
Thank Charles for that. He must have known. He knows I tend to talk long.
Okay, so first I wanted to tackle a few questions about the biological mechanism of long COVID. And the first question here is, why are so many of us getting new symptoms a year after the initial infection?
Can you give me just one quick second? I have a tiny little household emergency here, and I'm
Sure.
going to be just a second.
For those of you who are watching, if you want to submit a question, our team is monitoring the YouTube channel for questions as well as the Slack. And we are still accepting questions at this time. So feel free to ask away while we have Dr. Klimas's time.
Okay, sorry. I have to first show my summer intern is here with me. See?
You are so lucky to have that assistant.
Oh my gosh, this is what's made the COVID year bearable. I can tell you, she was born on March 30th last year. I didn't get to be there because of COVID, but here she is, happily helping out with all my lectures now. The whole year she's been Zoom bombing. Anyway, can you repeat that question for me and I'll see how I do?
Sure.
Okay.
The question is, why are so many of us getting new symptoms a year after the initial infection?
That is so interesting that that's happening. And I think that there is a number of different possibilities, okay? So one thing that happens when you have a chronic illness is that you don't do as much, and then you decondition, and then deconditioning makes everything worse, okay? So that's one thing that's probably always happening. That's just a thing, okay? It's not that, and that would make everything worse. It's not one symptom that would be worse, but the dysautonomia in particular would get a lot worse. The ability of your vascular tone of your arteries to maintain normal vascular tone when you've been doing a lot of lying down, because actually gravity really helps vascular tone. So one of the things you can do for the deconditioning part, first, just for the dysautonomia, is put the head of your bed up a little. Put about 6 inches of something blocked under the head of your bed so that you have a little gravity when you're lying down, even at nighttime. It makes your vascular tone work while you're sleeping, and it keeps you from being quite as deconditioned. It's a silly thing to do, but it actually very, very helpful. The other thing the reason why people go to bed, because they feel so awful when they try to do anything, is that they're trying to do too much when they try to do something. And that's very, very personal. And some people can tolerate 1 minute or 30 seconds. Some people can deal with 10 minutes or 15 minutes of something before they notice that they're getting relapses from that. But then once you start hitting that wall a lot, you just stop even trying because you hit the wall so much. And then you're kind of worried about why. The baby keeps crying over my lap. Then you're just in trouble once you stop trying. So what I usually tell people, what we do in the clinic is different. We can put them on that exercise bike you saw on my slide with a gadget there that tells us at the point they hit their aerobic threshold. So what that means is that when you're exercising, you're using oxygen and glucose to make energy until you can't anymore. Think of a marathoner that's gone 14 miles and then get that cramp and they have to stop, right? They hit their aerobic threshold, but they had a 14-mile aerobic threshold, not too shabby, right? My people hit their aerobic threshold at 3 minutes. The average on that bike is 8 minutes. That's the average. But I mean, I have people that hit their aerobic threshold going from lying down to sitting up and getting on the bike. I have people that go on the bike and they've already hit their aerobic threshold before we start. That little bit was enough. So it's very personal how severe your illness is and where that threshold is. But if I didn't know what your threshold was, I was just giving you random advice to strangers, which is what I'm being asked to do right now, I would say don't do more than 3 minutes. When you first get on some sort of exercise, you should have a watch on that does a pulse. And you should know first that if in the morning you wake up and your pulse is already elevated before you get out of bed, it's going to be a terrible day. It's not a day to do exercise. But if you wake up in the morning lying down flat and your pulse is like kind of okay, cool, I'm 60, 70, maybe even 80, but I'm not 110. Well, then I could probably do a little something today. That little something might be a 3-minute exertion. And it could be a very little exertion, a 3-minute walk. Or if you got my favorite thing is a recumbent bike, because you're safe. You're not going to fall off of it. You're not going to faint off of it. And you can set the resistance at different levels. And do just 3 minutes and try to get your pulse to go up about 30 or 40. That might take about 10 seconds, or it might take 3 minutes. Don't know, because I don't know you. But when you get your pulse up to about 30 or 40 higher than your baseline, you should stop and let it go all the way back to baseline, whatever that baseline is. And then do it again. And do it a few times. And that's how you rehab a patient with long haulers. You don't do it saying start with 5 minutes, go to 10, go to 15. You will always relapse if you try to go for endurance. But if you do what they call interval trainings, 2 or 3 minute efforts with lots of rest in between, 2 or 3 minute efforts, you'll be able to rehab better that way.
On this topic, if a long COVID patient wanted to enroll in a rehab protocol for long COVID patients, how do you recommend they evaluate whether or not it's safe for them, whether it's a safe protocol for them?
Well, I do think that exercise physiology step that we do with the bike and the actual exercise physiology cart is the safest way to find out what their aerobic threshold is and keep them under it. Okay, that's the safe way. But I mean, I'm not quite sure how they evaluate in a rehab setting for safety. I got the Zoom bomber.
Maybe they can help with some of our questions.
She's the best. Oh, she's off and running. She just learned how to crawl. She's almost walking, so she doesn't hold still very often.
That's an exciting time.
It's very cute. So anyway, I don't know what to say to that one other than I like the idea of knowing what your aerobic threshold is. And there are ways to calculate that without actually getting on the bike, and physical therapists know how to do that.
Okay.
Okay.
So next question, can you talk about the role of the vascular system in mast cell activation, ME/CFS, and dysautonomia?
It's just like another hour lecture, right?
I know.
So the first thing to know about mast cells is that they can pop, and that's anaphylaxis, or they can leak, and that's chronic disease. Okay, this is a leaking situation. So sometimes it's really hard to diagnose, because the diagnosis has to do with measuring histamine and tryptase in your bloodstream, and you have to release a lot of it all of a sudden to get up to the threshold. But you may have to have a presumptive diagnosis rather than a confirmed diagnosis. I would say less than half of my mast cell activation patients have a confirmed diagnosis. And yet I am convinced from their response to treatment that I nailed it. It's mast cells. So I would never deny someone a mast cell approach if I failed to find the histamine or tryptase on the blood test. That's one thing to say. But anyway, the mast cells are everywhere, and they are particularly in the endothelium, and they particularly mess up endothelial things like autonomic vascular tone and so on. And so they have a tremendous amount of symptomatology that affects the autonomic nervous system. But they're also in your gut, so they really affect the way your gut feels. They can trigger in your gut from specific foods. And they trigger on adrenaline. So they can trigger with stress. So mast cells are touchy little devils, and they trigger a lot. So, and some drugs trigger mast cells. A lot of psychotropic medications, including antidepressants, can trigger mast cells. So actually, again, that website I linked you to, terrific mast cell descriptions on that, and also there's a couple of really great lectures that you can find on YouTube from some of the big wizards of mast cell that are worth listening to. So that is another hour.
Yes, it is. Mast cell activation is a hot topic in our group.
Yeah, Dr.
And there's been a lot of discussions.
Yeah, we're excited because Dr. Theoharides from Tufts is going to come do a sabbatical with us for the next year in July. So we're going to become
that's excellent.
About mast cells next year. We're all just can't wait till he gets here. We're just going to pepper the poor man with questions for a year. Poor guy. But he's coming specifically to study long haulers. That's why he wants to work with us. He wants to study.
That's great.
Yes, it is great because he's a real important guy in the world of mast cells. So that's great.
So a question, this has come up in our support group quite a bit. There's talk about this transition point at the 2 to 3 year mark after the initial onset in ME/CFS. Can you talk about that a little bit and what long COVID patients should know about it?
So I think we made that up. I'm going to say that. I don't honestly think there's a 2 to 3 year transition point. When we do science, we find these cut points and we look at our data before 3 years and after. But did we look before 2 years? No. Did we look before 1 year? No. We just grouped all the 1 to 3s in one lump and said, oh, look, the before 3 years look different than the after 3 years in this biologic way. So for instance, we published a paper with Mady Hornig at Columbia, where she did beautiful cytokine data and said there was a different cytokine profile and more inflammation in the early stage of ME/CFS than we could find in the later stage of ME/CFS. Cool, great study. But did it tell us, exactly what that means in terms of prognosis? And did it tell us, even if 3 years mattered, what if we'd said 18 months, would we found something else? I don't know. So I don't believe that. And the first person to put that forward, also, I heard him do it in a lecture. I won't mention his name because that's not nice. But he just said it, and everyone embraced it. And I'm like, because your clinical experience has been that people sicker than 3 years stay sick. That's not been my clinical experience. Okay, my clinical experience is if you get the right intervention at some point in your lifetime, things start getting better. So I've seen people get better after 20 years or 30 years of illness. So I don't think that it's fair to say you're stuck in a chronic illness forever if you hit a certain point. And honestly, it's so depressing to people to hit that anniversary and feel like now I'm trapped forever. And we made that up. I mean, why should we have done that? That's not right. So I consider it a make-believe time point. That's my answer to that.
I think your answer will provide a lot of relief in that area because there's been a lot of fear. Okay, just one more research question and then we'll let you go. How can the long COVID community best influence the NIH to allocate its long COVID funding to projects which build on existing knowledge about ME/CFS and related illnesses?
Well, bless you for saying that. Let's just say that as a person who spent the last 30 years trying to build that knowledge and then feel like it's just being swept aside. Let's do a do-over. Wow. Yeah, I'm, it's a bone of contention with me that we would just start from scratch. And honestly, it's so important to me that we include ME/CFS as the sick control group in the studies that we do, so that not only do you get to benefit from what we already know about them, but also they get to benefit from what we learn about you and all the money that's about to be invested in you that has never been invested in them. It's really not fair that that's what happened. And it's really wonderful that you have managed through your advocacy in partnership with the ME/CFS advocacy community to be so effective as to get this $1.15 billion into the NIH budget. But you've got to watch that money like a hawk now, because there's going to be a real effort to use that money, not completely inappropriately, but you just don't want it to be disproportionately for the long-term lung disease, the long-term heart disease, and other things that aren't this disease. So you it's very clear to me from even the things we've seen presented to us so far from the long haulers presentations that were put together by the NIH and the CDC and so on. And when they're presenting, bringing the experts together, the experts are mostly people expert in post-hospitalization next few months sequela, right? And that's not what we asked them to do. So, and right now is a really good time to influence that, because right now, the reviews were due yesterday for your first very large investment in your field. So it wouldn't be a bad time right now to be reminding NIH leadership what that money was intended for as they're making these decisions who to fund. And they're making the decisions. I mean, they're deciding to fund these things over the next 2 to 3 weeks. And they're saying they're starting that whole big cohort development operation on May 1st, funded. So you've got 2 weeks.
Wow.
Very important time to speak very loudly that PASC, P-A-S-C, was their term for long haulers, because it's a term that can be used in a very different way. So I would just heads up on that. You use your advocacy voice loud and clear right now, that's what that money was intended for. Okay, so
Yes.
it's really important.
Thank you so much for offering your perspective on that. Body Politic has been involved with NIH and the Patient-Led Research Collaborative, but we still have a lot of work to do to make sure that we don't reinvent.
A lot of money, and this is their first investment, and I will give them credit for rolling it out so quickly and having a strategy. A strategy to get it out fast and to get these cohorts developing. Because honestly, you can't do science without patience. Yeah. It's a gift to you from her. Thank you. Good plan. Yeah. So, I'm really excited that the NIH came up with a strategy that could take an idea, that you got funded in February, and have a call for proposals, more than 200 protocols. And I mean, I wrote one of these myself. This is the kind of grant you write over 6 months. And we had a 20-day window from the time the thing was released to the time it was due. And we submitted a quality project that would have taken us normally 6 months of a lot of work among the teams to do it. We got it out there. And so did a lot of other people. And that's impressive. And I was telling you while I was waiting to give the talk, that Sutton's law applies here, that in ME/CFS, there's been very little money and the perception that applications weren't getting funded. So very little inducement to bring people to the field. The one time when they set aside a small amount of money, about $3 million, our average number of applications per round was about 3, and it went to, I think, 33 that one round, just because they said they would actually fund $3 million, which is what? It's like 4 or 5 protocols at best. It wasn't very much, but yet they got a bigger reply. Here you dangle $1.15 billion, and there wasn't anyone that didn't apply. Every major hospital system and university applied for this money. So Sutton's law, they rob the bank because that's where the money is. If you go to, why do you do post-COVID research? Well, that's where the money is. Honestly, if it brings all these amazing scientists to the field, yay. Absolutely yay. Even as a person who might get crowded out, yay.
It's been long overdue, I think.
Yeah, it is. It's exciting.
Well, with that, we will wrap up. Thank you so much for offering your time and your expertise and all of the work that you do for long COVID patients and people with ME/CFS and other illnesses.
Oh, you're welcome. And I'm sorry for the baby bombing, but that was fun.
It's life during the pandemic, right?